A very good morning and welcome to all of you to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. I hope all of you are staying warm and safe. And I'm Arvind Bhimaraj. I'm the Interim Division Chief of the Division of Heart Failure at Houston Methodist Hospital. And I have my co-host here, Dr. Ali, who's our first-year cardiology fellow aspiring to become an advanced heart failure cardiologist and a rising star in the field of heart failure. Before we move on to our exciting talk today, just a few housekeeping comments. If you have questions, you'll have instructions that will come up on the screen, but you can either text to DeBakey to 37607, or you can go to pollev.com and enter DeBakey. So kindly use that opportunity to send in your comments and questions all throughout the presentation, and we'll address it at the end. Also, a reminder to everybody that this is Heart Month and Heart Awareness. Everybody should do their part and can do their part. And more relevant to today's talk, next week is Heart Failure Awareness Week, which is a personal passion for me because the disconnect between general awareness about heart health and the specific awareness about heart failure as a disease entity, as simple as connecting the dots for uncontrolled hypertension and diabetes, is lacking. So I would urge all of you to use that opportunity to do your part within your communities, within your areas, to promote awareness about heart failure. Today we have a special guest, and I'm very excited to introduce our guest speaker today, a name that's well known in the field of cardiology. Dr. Clyde Yancy is the Vice Dean of Diversity and Inclusion at Northwestern University Feinberg School of Medicine. He concomitantly serves as the Chief of Cardiology at the Northwestern University and also the Associate Director of the Bloom Cardiovascular Institute at the hospital at Northwestern Memorial Hospital. He holds the Magerstadt Endowed Professor of Medicine chair and also holds an appointment as Professor of Medical Social Sciences. Dr. Yancy is no stranger to the South. He's a native of Louisiana, earned his early education from Southern University and Tulane University, and then spent a considerable amount of time in Dallas training as faculty for many years. He trained many of my friends and colleagues and trained many individuals throughout the country in the field of heart failure. In 2006, he was named as a director of the Baylor Heart and Vascular Institute in Dallas. And testament to his dedication to education, in 2010, he in fact did a Master's of Science in Medical Management at that stage, with, of course, all the responsibilities on his shoulder. Dr. Yancy's research interests in heart failure, guideline generation, outcome sciences, personalized medicine, and healthcare disparities are known to all. He's extensively published with over 500 peer-review publications, an H-index of greater than 100, and has contributed to many of the guidelines which are, pretty much Bible for us when we practice medicine and practice heart failure. Dr. Yancy is the deputy editor of JAMA Cardiology. He's a senior section editor of JACC, and also serves on the editorial boards for Circulation Heart Failure, the American Heart Journal, and JACC Heart Failure. Dr. Yancy has served in many leadership roles apart from the practice guidelines writing committees. He was the co-chair of the ACC Diversity and Inclusion Task Force. He was a former president of the AHA and a recipient of the Gold Heart Award and the James Herrick Medal for Distinguished Achievement in Clinical Cardiovascular Medicine. As all of you know, I can probably spend an hour of grand rounds talking about all this achievements. On a personal note, Dr. Yancy has always been an inspiration to me, many of my colleagues, and young aspirants like Dr. Ali, who's here with me. And I've always walked away with intellectual conversations and insightful conversations with him, thinking that every word he says has a weightage to it, and literally every word and pauses that he has. Eloquent speaker, inspiring, and we're really honored to have you today, Dr. Yancy. Over to you with no further ado.
Dr. Bhimaraj, thank you for that incredibly generous and kind introduction. I am so honored to be a part of today's presentation. Please confirm that you're able to see my title graphic.
Yes, sir.
Great, thank you so much. Well, my good morning to all of you who are listening in today. We continue to find a way to move forward in this virtual world and look forward to a time when we can be together in person. I want to start by extending a warm greeting to my close personal friend and professional colleague, Bill Zogby. We've known each other for many years and have worked together on national and international objectives and have become close friends. And Bill, I'm so grateful to be with you today. I paid particular attention to the opening montage featuring Dr. DeBakey. Dr. DeBakey also is an alum of Tulane. I had the opportunity to attend Dr. DeBakey's funeral on behalf of the American Heart Association. And it was at that moment that I began to understand the presence, the impact, the influence that a man of his stature had in the field. Certainly not a perfect human, but an incredibly dedicated, passionate practitioner and investigator, really setting the bar for all of us. In that keeping, then, I hope that this Grand Rounds presentation would meet his satisfaction. I was challenged by you. You gave me a title, The Changing Landscape of Heart Failure Care, with a subtitle that's very important, Societal Relevance and Importance of the Field for the Health of the Nation. I thought about this for quite some time, got fascinated with the intersectionality of this, and recognized that the best way to do this was to deconstruct the title. So I'd like to spend the first half of my time talking to you about the changing landscape of heart failure care, and then spend the second half of my time thinking about the societal relevance. And I hope that you'll stay engaged with me the whole time and recognize that there is, in fact, true intersectionality here. But let me remind you of something. If Dr. Zogby's listening in, he'll remember that I was with you in person 7 years ago. Houston Methodist DeBakey Heart and Vascular Center Grand Rounds, the treatment of heart failure in 2014, an evidence base that is still lacking. I intended to be provocative with my title. What did we talk about then? Very quickly, I'll remind you that we went through a continuum that started with risk factors and led ultimately to progressive disease. This was an adaptation from a 1991 model set forward by Victor Zhao and Eugene Brunwell. I then overlaid the contemporary stages of heart failure to demonstrate that the thinking of our forebears, Dr. Zhao and Brunwell, was in fact prescient because it identified that we would eventually understand that heart failure occurs along a continuum, and that has forced us to think more carefully about the early elements of the disease, the early stages of the disease, indeed the risk factors, and we'll come back to focus uniquely on diabetes in a moment. But what else did we talk about? Well, we talked about the 2013 iteration of the guidelines of care. I had the pleasure of chairing this guideline statement and remained chair until 2020 and just yielded to Baiken Boxkert and Paul Heidenreich. But this was our best understanding of what was appropriately indicated for reduced ejection fraction heart failure. You see therapeutics that now are legendary, ACE inhibitors or ARBs, beta blockers, mineralocorticoid antagonists, loop diuretics, and for African Americans, hydralazine and isosodium nitrate. This was foundational bedrock therapy. But is that still the same case for today? What else did we talk about in 2014? Well, we bemoaned the fact that for all of the therapeutics that have been tested, there was nothing that had yielded a positive signal in the treatment of heart failure with preserved ejection fraction. And we began to have these very important conversations going back to define the disease. Is this all one entity? Is there too much heterogeneity? We'll show you some updates on HFpEF now. And then we had this. What about readmissions for heart failure? The hospital risk readmission reduction program, or HRRP. Do you remember the elephant in the room? In fact, it was this conundrum that was penalizing hospitals across the country for readmissions due to heart failure. And this was top of mind, a very topical conversation in 2014. That seems to have quieted, although the burden of hospitalization remains. So let's move forward to where we are today. Again, in 2013, we worked diligently to establish a contemporary suite, SUITE, of definitions relevant to heart failure with reduced ejection fraction, preserved ejection fraction, but we were once again perhaps prescient in that we had this notion that perhaps we could use the guidelines to provoke a different thought process, understanding how unsuccessful we had all been in elucidating therapies appropriate for HFpEF. So we opine in the guidelines that maybe HFpEF is an amalgam of different phenotypes. Perhaps there's borderline reduced ejection fraction, 41 to 49. We call it HFpEF borderline. Right now, we would call it mid-range ejection fraction heart failure. But we also stridently put forward this notion that there were some patients who previously had reduced ejection fraction heart failure, but their ejection fractions had improved greater than 40%. Certainly, if you put all of them in a bucket of ejection fractions greater than 40% and call that HFpEF, clearly there are different characteristics. That's been the prevailing definition. But again, working with Dr. Vascular and others internationally, we have evolved a new universal definition and classification of heart failure. And look at the number of collaborating societies. Dr. Bhimaraj is right. Next week is Heart Failure Awareness Week. Look at all the societies across the world that are engaged with advocating, understanding, knowledge, activity in heart failure. We look forward to the release of this definitional statement because we hope that that will redefine our awareness of heart failure, our ability to manage heart failure, and our understanding that we likely need to go beyond the ejection fraction, just giving you a bit of a hint of what you might expect when this document emerges. So let's think about that original model from 7 years ago that I shared with you, where we embraced the presence of risk factors and talked about early stage disease. What do we know about prevention? Is that not an incredibly important moment? There now are evidence-based strategies to help us understand this. Let's go back to the template. Whenever we talk about guidelines, we come back to this image. It portrays the 4 stages, the progression of disease, the risk factors, asymptomatic LV dysfunction, symptomatic disease, either ever having had symptoms or current symptoms, bifurcated into HFpEF and HFrEF by the prevailing definitions that I've just shared with you, and then progressive disease, the management of which your DeBakey Center has been prolific over the last several decades. If we focus on prevention, though, here is the important information. This is from 2015, since I was last with you. The SPRINT trial. I had the privilege of being one of the parties directing the DSMB for this trial and making the decision to halt this trial prematurely, because once we saw that we were able to separate the curves by aggressive treatment of hypertension in those with increased cardiovascular risk, we saw this, a decided advantage driven by overall mortality and especially by heart failure, nearly a 40% reduction in episodes of de novo onset heart failure sufficient to require hospitalization. That's a pause moment, because it means for the first time, we demonstrated that the effective treatment of hypertension in higher risk individuals, absent diabetes, because that was an exclusion, does in fact result in the prevention of heart failure, a profound statement that we were able to make for the first time ever. But then these data came about. I won't take you through the entire regulatory history, but in the pursuit of agents that could safely lower blood sugar, it became evident that so many of these agents had cardiovascular consequences that were adverse. And so the FDA declared that for future consideration, there necessarily must be a safety component of the trial to ensure that the benefit on blood sugar did not come at the cost of a detriment on cardiovascular outcomes. So in these safety data, what was remarkably identified in the very first set of trials done with the SGLT2 inhibitor, sodium glucose cotransporter 2 inhibitor, and empagliflozin, was this: a decided and unexpected reduction, dramatically so, in hospitalizations for heart failure. There is a signal on death, but that was probably a statistical fluke. It's not been replicated. But nevertheless, in the diabetic patient, this reduction in hospitalizations was absolutely profound. I've just shared with you then two themes of evidence different from 7 years ago, showing that we can prevent heart failure through the effective treatment of hypertension in high-risk individuals. And then in diabetic patients, particularly those with cardiovascular risk factors, a decided reduction in new onset heart failure. Well, this launched an entire suite of trials and an entire effort to understand, can we replicate this? And yes, we could. The empagliflozin protocols, the canagliflozin protocols, the dapagliflozin protocols, all looking in patients with diabetes, with existing atherosclerotic disease and without, a consistent signal demonstrating a reduction in de novo heart failure. Very important information. But the story continues because most recently, we've identified that we can go back to the pooled cohort equation that we use to predict the risk of atherosclerotic events, and we can now use a pooled cohort equation to predict the likelihood of developing heart failure. Again, if we're thinking very carefully about hypertension, we have these two important interventions, and now we have an online tool using the same pooled cohort equation that we've used previously to help us understand who's at risk and who would benefit from the more aggressive interventions. Additionally, we have yet another tool, which is very simple. It's called the H2FPEF score. I'm delighted that a fellow is the co-host because this is something I want all of the fellows to put in their smartphones or put in the pocket of their coats. Keep this in mind. This is a very simple risk score. H2, heavy hypertensive, F, atrial fibrillation, P, pulmonary hypertension, E, elderly, F, filling pressure. Look how easy the score is. It's arithmetic. Add up the total points and then scale the probability of having HFpEF in the patient with symptoms, that is with dyspnea. This is a very insightful exercise, helps us better identify those with HFpEF and initiate earlier therapies, particularly as we pursue the concomitant comorbidities and make interventions there. We also need to understand this. We did not appreciate just a few years ago how important it was to discriminate risk as a function of sex. Women bear disease differently, and particularly for HFpEF, they uniquely bear that condition differently. We need to think about the consequences of pregnancy. We need to think about the consequences of chemotherapy. We need to think about the consequences of lifestyle and the adverse influence that happens when there's not a healthy diet, when there's not physical activity. This model put forward by Dr. Dolbear and others is incredibly profound and really helps us target our lens on prevention in women as we should. But let's move from there and think about what's the current treatment paradigm. I showed you what the paradigm was in 2014. But what about now? Well, we go back to the same template that we've been using that has never failed us. This came about in the 2005 iteration of the guidelines and had a preceding infrastructure thought process in 2001 and 2002. But now it is deeply embedded in the way we think about this condition. Note the subtlety here. I've moved the intervention arrow, the purple arrow, from stage A to between stage B and C because there's some circumstances where in the setting of asymptomatic LV dysfunction, we do introduce therapy, whether it's RAS inhibition, those with familial cardiomyopathies that we think are going to be rapidly progressive, or ICD therapy for those patients with reduced ejection fraction due to ischemic heart disease. And then we go forward with additional other indicated therapies. We now have this algorithm that we've not ever had before. This takes all of the highly regarded evidence-based therapies and puts them in a treatment cascade. It starts with step one. Take a picture, understand the patient has reduced DF heart failure. The obligatory recommendation as we speak is RAS inhibition with diuretics as needed, plus an evidence-based beta blocker. At step two, we go through a set of interrogatories. These 6 interrogatories independently anticipate an indication for an evidence-based strategy. They are not mutually exclusive. This allows us for the first time to develop a quasi-personalized approach in the care of patients with reduced ejection fraction heart failure. And it's only when this model fails that we go to step 4, which prompts additional considerations for more advanced disease. Now, this is a lot to remember. And so part of what we did when we put this together was to come up with an app. This is the Treat HF app. Again, for the fellows, if you don't have this on your phone, take a moment, go to Google Play, go to the App Store, look for the Treat HF app. We are updating that app, and I'll tell you about that at the very end. But it makes it so that you can input the data for your patient. The app will then work through these 6 interrogatories and not only help you anticipate what's indicated, but will give you a link to the references that will substantiate the reasons that these therapies are indicated. But let's continue, because now we have to go beyond 2020. We're into 2021, and we're thinking about what are our current challenges. This is our current challenge. Despite what we've learned in the past 7 years since I was last with you, we know that even with this robust evidence base, only 1% of patients in this important CHAMP-HF registry published just 2.5 years ago were receiving indicated therapy for reduced EF heart failure in the doses that had been proven to be most effective in the randomized control trial. 1%. Let's just stop for a moment and think about that. These were sophisticated practices, seeing patients with symptomatic heart failure, and only 1% of the patients received ideal care. Less than 25% of the patients received reasonable care, meaning at least one candidate drug from each of the 3 buckets: RAS inhibition, beta blockers, or an MRA. That really made us understand that particularly for heart failure, we can do better. Again, another reason why the upcoming Heart Failure Awareness Week is so important, because yes, we need to alert the community to this condition, but practitioners need to understand we're not where we should be. If you then say, well, maybe those data just overrepresented things, and they were perhaps baseline data. These are the data at 12 months. The red pieces of the pie tell an even more distressing story. There was no change over 12 months. If it's red, that means it was at a sub-target threshold or not initiated, whether it was RAS, RNA, beta blocker, or MRA. A big concern, and this is just several months ago. So what are 3 solutions to this? We know what to do. How can we do it better? Here are 3 provocative solutions. Solution number 1, can we use machine learning overlaid in our electronic health records to prompt us appropriately for when we're missing an opportunity to either titrate or to add evidence-based therapy? Here's number 2, maybe we move away from this notion of target doses and all of the angst that comes from titrating up to these doses. Maybe we evaluate, is there a synergistic effect with modest doses of each of the indicated drugs sufficient that we can replicate outcomes that rival or exceed what was seen in clinical trials? But here is another concept, and I'm delighted that one of my fellows, Dr. Agarwal, soon to be one of my early career attendings, is leading this trial. We now have funding for use of a heart failure polypill. We'll launch this in a middle-income country, India in particular, but it will have components of an ARB so we can avoid angioedema, a generically available but indicated beta blocker, carvedilol, a small dose of an MRA, and a diuretic, a polypill. We've already done the compounding. We have the formulation in hand. It will be very inexpensive to give. It will be a single pill that will replicate the benefit of the multiple indicated therapies. We articulated this in a viewpoint that we published just several months ago, and we will soon be launching this trial. If this works, this may be something that is relevant, not just for a middle-income country, but for a higher-income country as well. 3 solutions to how we can improve adherence to evidence-based care for heart failure. But what about new relevant data now focusing on HFpEF? I showed you in 2014 just an incredible array of negative trials, and I showed you how the definitions had all conflated to represent just the metric of an ejection fraction. Well, this is what's important. I want you to understand what we're thinking about now with HFpEF. Here at Northwestern, we really have been quite strident in our assertion that there are at least 3 major phenotypes. There is a cardiorenal phenotype that really is predicated on the way in which blood volume is regulated. that may be amenable to some very exciting strategies, one of which we're pioneering here at Northwestern using spinal nerve denervation. It was started by a group at Duke, but we want to apply it to HFpEF as a way of dealing with the cardiorenal HFpEF. What about cardiopulmonary HFpEF, where there is inappropriate secondary pulmonary hypertension, particularly with exercise? Is that a condition that will be uniquely beneficial to something like a neprilysin inhibitor? And then there's the cardiometabolic phenotype, as depicted here. We understand that adiposity is not dormant. It's not a static tissue. It is, in fact, metabolically active and elicits a pro-inflammatory response. And you compound that with aging, and you begin to understand a very provocative cascade that in the setting of hypertension, aging, poor fitness, sedentary lifestyle, the metabolic stress of obesity, there are important vascular changes, and those changes may end up leading to the stiffness that we all characteristically identify and leading to symptomatic heart failure. Our best data addressing this has been looking at the Paragon HF trial. This again identified HFpEF by ejection fraction, but also by biomarkers, so a little bit more specificity using the RNA compound as a way of intervention. I share these data with you. All of you in the room know that this was a neutral trial. I'm careful not to say negative. You know the design of this trial. There was a run-in, a randomization, valsartan versus a combination of sacubitril, valsartan, and a very important primary endpoint of total hospitalizations, not just first hospitalization, and cardiovascular death with important secondary endpoints that you see here. These were the data. Truly a near miss. Using frequency statistics, the p-value was 0.059. A few more events and this would have been a statistically significant trial. We understand in this trial that death was not the driver, but heart failure hospitalizations was the driver. These findings have remained provocative sufficiently so that the FDA is currently evaluating an indication for RNA for HFpEF along the lines of these data, even though it was a neutral trial. The data become even more provocative when you look at the difference by sex, women having a stronger signal than men. And if you look at the difference based on not the a priori definition of HFpEF, but the median ejection fraction, those patients at or below the median of 57, another provocative signal. It will be very interesting to see how the FDA adjudicates these data. The FDA hearing has already been held, and the advisors suggested that we should go forward with a label indication. So this is clearly new information, the new consideration since 2014. But what about the SGLT2 inhibitors? Does that not add more to this? We think it does. I've already shared with you the prevention data. These were the incredibly profound findings from DAPA-HF published in the summer of 2019, about 15 months ago now. We look at these data and we see a consistency of treatment effect for the primary outcome for hospitalization, for mortality from cardiovascular cause, and mortality from any cause, a profound treatment effect. What made this so incredible, and another pause moment, is that whether or not diabetes was present, the benefit was observed. So DAPA-HF moved us beyond this being a hypoglycemic agent to this being, for certain, a cardiovascular therapeutic, demonstrating benefit in those with and without diabetes. So this really was an inflection point in the history of the care of patients with heart failure. Those of you that are of my generation will know we've had several inflection points. The introduction of the ACE inhibitor, the introduction of the beta blockers, the introduction of the RNA compound, and now the introduction of the SGLT2 inhibitors. Benefits seen in those with without diabetes, once a day therapy, no need for titration, no episodes of hypoglycemia and diabetic ketoacidosis, negligible incidence of amputations, a number needed to treat of only 21, and for the first time data seen that was beneficial in those beyond the age of 75, still wrestling with the mechanism of action. But then these data were further empowered when we saw this press release from July 30th, and then this publication in the New England Journal of Medicine, August 29th, 2020, This is now the Emperor reduced study that looked at both cardiovascular and renal outcomes in patients with heart failure. This was not a near miss. This was a home run. The primary outcome, the hospitalization burden, decidedly benefited by the use of empagliflozin. So 2 trials now, dapagliflozin and empagliflozin base, demonstrating a benefit in heart failure with or without diabetes. But something else evolved. Looking at changes in GFR, we recognized that the use of the SGLT2 inhibitor attenuated the decrement in renal function that is so often accompanying heart failure and challenging our ability to care for our patients. Concomitantly, we started seeing data that elucidated what is this intersectionality between the kidney and the heart, and it's real. We recognize that RAS activation, issues of inflammation, fibrosis, all are collinear. That is, they occur in both the kidney and in the heart. DAPA-CKD was really an important trial because it looked at the use of dapagliflozin in patients with chronic kidney disease. The primary outcome was a change in renal function or death from renal or cardiovascular causes. The treatment benefit was so profound that this study was stopped early before follow-up was completed because of a number needed to treat of only 19 and a profound benefit in favor of attenuation of the progression of renal disease and preservation of death from renal and cardiovascular outcomes. And this curve, looking at estimated GFR, exactly superimposable on the empagliflozin data. But then in the fall of 2020, we had even more data. This now looks at a sodium glucose cotransporter inhibitor that targets both receptor 1 and receptor 2. These data in patients with diabetes and chronic kidney disease using sotagliflozin showed a reduction in the progression of renal disease and cardiovascular renal events. The data that I am so persuaded by, though, come from the SOLOIST worsening heart failure trial. In patients with diabetes and recent worsening of heart failure, when sotagliflozin was started either during the hospitalization or shortly thereafter, a dramatic reduction in subsequent heart failure events, more side effects perhaps related to inhibiting both the SGLT1 and 2 receptors, but nevertheless, consistency of a signal here. So here's a full portfolio of opportunities with the RNA compound and the SGLT2 family. For HFrEF, you can see an RNA compound indicated. For HFpEF, pending. For intermediate ejection fraction at mid-range, pending. SGLT2 inhibitors, as we stand today, not currently supported by guidelines, but in keeping with my disclosures, indicated therapy already by the FDA. For HFpEF, we're waiting Emperor Preserve. We have no data on mid-range, and then there are a number of emerging therapies that I'll get to at the very end. But this lets us understand that we clearly have new opportunities to treat heart failure that 7 years ago when I was with you were simply not available. What's the latest data? Well, here's the latest data. We know that we have several drugs. Vericiguat, a soluble guanylyl cyclase inhibitor given to patients with worsening heart failure, a modest benefit on outcomes. Omecamtiv mecarbil. This is the first myotrope we have, not inotrope, myotrope, because it improves the efficiency of myosin actin interdigitation. And ferrous carboxymaltose. In the AHF trial, the addition of intravenous iron to patients recently hospitalized was a benefit. Now, for your perusal in the full set of presentations that I've made available to your CME office, I have the additional data supporting these therapies, but I wanted to just highlight these therapies because over time, there will be the necessity for us to consider a vericiguat, omecamtiv, and ferrous carboxymaltose will enter the treatment armamentarium for heart failure. But now I wanted to fulfill my word to you, which was to go back to the title that you gave me. And I really am grateful that you gave me this title because you wanted me to talk about the societal relevance and importance of the field for the health of the nation. You gave me a broad target. And I thought that the best way to put this target in context is to understand the journey we've been through, specifically COVID-19. And uniquely, the way in which COVID-19 has revealed the extent to which there are healthcare disparities in this country. Here in Chicago and there in Houston, there was sobering, disconcerting evidence of poor outcomes. In Chicago, it's a function of race, blacks versus white, and in Houston, as a function of ethnicity, looking uniquely at what was happening in the Hispanic population. These are the data that are aggregated by the American Public Media Research Lab website that follows every 10 to 14 days updates on deaths by race and ethnicity. Here are the key findings. Through February 2nd, I want you to look at two variables for a population that you appreciate well, the Latino population in Houston. 1 in 835 Latino Americans in this country has died due to COVID-19. From my lens here in Chicago, 1 in 645 Black Americans has died due to COVID-19. And if you by chance care for any Native Americans, Indigenous Americans, 1 in 475 have died. This has been a compelling burden and a striking disproportionality that we cannot ignore. Look at the number of deaths for Latinos, 72,000, for Blacks, 63,000. This really has been a compellingly depressive and hurtful disease process that we've all endured. If you portray this graphically, you can see the relative increased risk of death as a function of ethnicity, Native American status, Black versus white or Asian. There's no question that disparities remain very much evident in this country. So with that in mind, how then do we reason this and how do we go forward? Well, in a different set of conversations, we would highlight the importance of the social determinants of health. I know you understand very well that there are certain neighborhoods in Houston that don't have access to the right kind of fundamental necessities to enable health. I would be remiss if I didn't articulate that some of these differences, quite frankly, are due to decades of systemic racism, particularly as it's defined by the pernicious impact of segregation, aggregating people to place, localizing their disadvantage, and then systematically disinvesting in those communities. It happens here in Chicago on the South Side. It happened in Dallas. It happens in Houston. But I'm going to just focus on one thing because it's something that we in healthcare, we as leaders in medicine can address. And it's the absence of diversity in science and medicine. What can we think about when we consider championing diversity? I want to share with you a profound statement from the editor of the magazine Science, H. Holden Thorpe, who doesn't respect science as a purveyor of the most leading edge data in our entire discipline. This is what Dr. Thorpe said. And then science and scientists finally need to listen to and make space for people of color to lead laboratories that publish great science and produce influential scientists, run institutions in their scientific units, and propel science and other journals to promote structurally underfunded scientists in areas of science. And then from the perspective of a successful scientist of color, we saw this. How much creativity are we leaving on the table? Because science repeatedly fails to come to terms with our narrowly defined processes and our limited ways of determining success. Think about the Texas Medical Center. Think about Houston Methodist Hospital. Think about how many students, physicians have come through your hallways, and then pose this question. If you were my peer as a professor or as a leader, how much creativity are we leaving on the table? It's a profound question. Let's continue though. Is there a solution? Is diversity the way that we address this? Well, what about lessons learned from corporate America? Be prepared for what I'm about to show you. If we look at the Harvard Business Review, Leaders who create inclusive environments where diverse voices are welcomed and engaged were nearly twice as likely as others to achieve value-driving insights. Employees in those environments were 3.5 times as likely to contribute their full innovative potential. As we recover from COVID-19, who doesn't want the full innovative potential of the entire team present? What about this lesson learned from Deloitte and Touche? Organizations with inclusive cultures are 2 times as likely to meet or exceed financial targets, 3 times as likely to be high performing, 6 times more likely to be innovative and agile, 8 times more likely to achieve better business outcomes. Look at your organization. If your organization doesn't have an inclusive culture, guess what? You're missing out on all of these opportunities. And what about here from Forbes? This is very sobering. Look at the prototypical decision-making body, all male, all white. If one adjudicates the quality of those decisions post hoc, 58% of the time, more than half the time, those decisions were deemed to be beneficial. But then just simply add gender diversity, it goes to 73%. Add age and gender diversity, the more seasoned members of the team, the early career members of the team, it goes to 80%. But when you add age, gender, race, ethnicity, geography, it goes to 87%. What entity, what institution, what enterprise doesn't want to see the decision-making process go from 58% success to 87% success? But you say medicine is different because we have a pipeline problem. Well, is that right? If diversity is a way towards excellence, then if there's a pipeline problem, we should fix the pipeline problem. But is there a pipeline problem? Well, let's look at these data published just several months ago in the JAMA network. Look at the number of residents in internal medicine, 2006 and 2018, and then look at the underrepresented in medicine. That's not an absent pipeline. Over 3,500 in 2018. Cardiology has a ways to go. And Dr. Zogby know that we're working diligently to change that. What about applications for medical school? This is from the ACGME. Look at 2015, 2016, the next fiscal year, the one that follows in 2018, 2019, the one for which we have the most recent data. Again, you can see by virtue of application, well over 4,000 applicants that are Black, well over 3,000 that are Hispanics. There is a pipeline, and the majority of these applicants are qualified, but something's happening. Here's what's happening, and this is why we challenge the notion that it's a pipeline problem. These data, again, from the ACMG, are compelling. Train your attention to figure 3. I want you to look at the association between medical school matriculant diversity and faculty diversity. For those faculties where a higher percent of the leadership, the professors, identify as being from underrepresented groups, there is a higher density of medical school matriculants from URM categories. It's very difficult to walk away from this associative statistic and say, would it not make a difference if we had more representation in the leadership suite at the professorial level and welcoming more diversity in our medical schools? Is that a root cause for why we don't see the diversity? Is that impeding our ability for excellence? Is that a path forward as we think about the societal impact? Or think about what we introduced in the literature just about 1 month ago. Out of frustration at the stagnant growth, particularly for Black men, we suggested this. If in fact the prevailing medical schools are unable to recognize the need to expand student capacity to incorporate more underrepresented minorities, maybe the path forward is to have more diversity in your leadership, as I've just shared with you. Understanding that if the existing schools did that, it would increase the numbers by between 150 to 300 per year, and over time would narrow that gap and diversify our workforce as physicians. Then what we argued as a bold alternative was to start a new medical school and to use a model that works. In fact, just yesterday, there was an announcement that the ACGME called out for the good the relationship between Emory and Morehouse as a model going forward to improve not just diversity, but actually the quality of care in medicine. And we had already suggested this a month ago in writing. Now, you might say, that's going to be very expensive, Clyde. How are you going to pull that off? You know what? Think about the cost of bringing one cardiovascular therapeutic to market, $1 billion. In today's world, you could start this school for 1/5 of that cost. In particular, if you align it with an HBCU and the same kind of relationship that Morehouse and Emory have, this might be a way of identifying that raw talent, piercing all the negative inertia, and illuminating arcs of success. So let's get back to heart failure and think about today's takeaways. That was the first half of which we wanted to discuss. Here's the summary. It is very important for us to recalibrate our focus and think about prevention. I think that is incredibly necessary. Number 2, we have effective guideline-directed medical therapy already, and we can fundamentally change the history of heart failure, but we have to use the therapies more effective. Number 3, we should at least understand we have the capability to more readily make the diagnosis of HFpEF, consider the comorbidities, but also understand that there are some unique opportunities that await. Perhaps the ARNI compound may even emerge with an FDA label indication. Don't forget that many times the diagnosis of HFpEF represents a conflation of hypertrophic cardiomyopathy and cardiac amyloidosis. We have exciting new therapies for both of those. So be very astute in the assessment of the patient with symptomatic heart failure and preserved ejection fraction. And then what about the SGLT2 class? Important breakthrough therapy for prevention, breakthrough therapy for treatment, breakthrough therapy for decompensated heart failure, breakthrough therapy for progressive renal disease, maybe even HFpEF awaiting those data. And then think about the additional new therapies that I mentioned earlier. They will continue to change the paradigm. And then let me call your attention to this. Just released is the 2021 update to the 2017 ACC Expert Consensus Decision Pathway for Optimization of Heart Failure Treatment. I was the chair of the 2017 statement, on the writing committee for the 2021 statement. Several things that are the important takeaways here. 3 big changes. The first, the RNA compound, is the preferred approach for initial RAS inhibition, decidedly different. Certainly, when you think about what I shared with you 7 years ago, major change in heart failure therapy. Number 2, the SGLT2 inhibitor now indicated as foundational therapy for HFrEF. Think about how far we've come in just 7 years. We didn't even have this in our vocabulary when I was with you before. And now it's emerged with amazing data and appears as foundational therapy for HFrEF. And this important statement, the new standard of care for HFrEF, quadruple therapy, the RNA compound, the SGLT2 inhibitor, the evidence-based beta blocker, and MRA. Stay tuned for the new guidelines, again, being chaired by Dr. Heidenrock and Dr. Boskirk, where we will further articulate evidence-based concepts and directives that will parallel what I've shared with you already. Finally, what's our path towards a better society in 2021? Don't we all wish to have a better society? Here's the first path. Let's learn from our recent past experiences. A civil society does not allow disproportionate suffering to the extent that we've realized. Number 2, let's recognize that all public policy is health policy, as all of the ills of society eventually become manifest as poor health and disparate health outcomes. And you know what? Those of you at Houston Methodist and my peers at Northwestern Memorial, we end up taking care of these conditions. And it all emanates from poor public policy. A profound statement, but one that's defensible. Understand that as painful as it is to articulate in here, systemic racism is important. Recognize the ubiquity of implicit bias and know that biased decision-making happens in life, and particularly in medicine, with less than good consequences. And then finally, can you today recognize the benefit of becoming a champion of diversity, not because it's the socially just thing to do. That's a great reason to do it, but because it's also our pathway towards excellence. Don't ignore the lessons learned from the business community. Realize that allyships that support racial, ethnic, sex, geographic, religious, disabled, and LGBTQ inclusion are really allyships that improve our society and put us on a path towards excellence. And then finally, when all else fails and you simply don't know what to do, stop, sit down, and listen deeply to others and understand the world through their lens. So I'm going to set the course for 2021 in the words of the rising star in our society, Amanda Gorman. She said this: "Let the globe, if nothing else, say this is true, that even as we grieved, we grew, that even as we hurt, we hoped, that even as we tired, we tried. The new dawn blooms as we free it, for there's always light, if only we're brave enough to see it, if only we're brave enough to be it." I'm so grateful to you for the opportunity to visit with you this morning, to present these parallel themes. So impressive of you to have the vision to say, we want to hear about heart failure, but we also want to hear about how we can build a better society. I hope I've given you important updates in heart failure, challenge you to some future treatment iterations that will lead to a better outcome for our patients with heart failure. But I hope I've also made you pause and think, there is a way to have a better society. The lessons we've learned should remain with us, and we can live differently. We can live better. Thank you very much.
And thank you, Dr. Yancy, for this very comprehensive and profound talk on heart failure and also diversity in medicine. Just to remind the audience, you can join us by web. You can go to pollev.com, enter DeBakey and enter your questions, or join by text. Text DeBakey to 37607. So one of the things that I was hoping to talk to you about, I think it's really inspiring to hear you talk about not only discovery science, but also implementation science. And as you mentioned, only 1% of patients who are eligible for HFrEF GDMT actually have received them. And I'm curious if you can share some of your thoughts about how. Is it the cost for the patients? Is it the socioeconomic inequalities, or maybe even systemic racism that's playing a role? And the solutions that you mentioned, things like the polypill, that's very intriguing. What are some barriers to actually implementing that here, and what are some ways we can incentivize?
It's a brilliant question. Thank you for raising it, because I want to be very plain spoken in my response. The barrier is us. It's the way in which we as practitioners interpret new information, the way in which we're hesitant to deploy new therapies, the way in which we are uncertain about whether or not this benefit will be seen in our patients. And so as a consequence, we are slow to move. Time didn't allow even more discussion about prevailing concepts in heart failure, one of which is that we're learning that it is a very time-dependent benefit. When you start an SGLT2 inhibitor, within weeks, that patient begins to experience a lesser need for hospitalization. When you start the RNA compound in a patient that's been hospitalized, within weeks, that patient is on a trajectory towards a lesser necessity for hospitalization. The famous wait and see, watchful waiting, come back to the clinic and say you're doing is failing us. It is a pathway, a paradigm for inaction. And so there are a lot of other answers I can give you, but the very first answer, one that you can operationalize today, the problem is us, our willingness to incorporate new data. Quite frankly, how comfortable are we with new data? This is why centers that have done very well with this have done well, because they've taken it away from the physicians and have used nurse-directed titration clinics or optimization clinics or recovery clinics. They go by a variety of names, but it's the same thing. By enabling PharmDs and nurses with appropriate algorithms and important caveats so we can arbitrate risk, we see patients are getting better and better. In our own nurse-directed PharmD-led titration clinic, over half of our patients are realizing improvement in ejection fraction of at least 10 points. It can be done, but we have to take us out of the equation because we're the impediment. A bit provocative, but quite true, I believe.
Yancy, I think very, very provocative and thoughtful insights, very relevant because sometimes we're lost in the science and humanity of medicine, but I think these social systems and gaps that you mentioned are probably what we need to pause more and talk about it. I have a comment and a question posed by Dr. Zogby. I was trying to see if I can get him on to grace his presence, but it was the last minute. But he says, thank you for such a wonderful presentation. A lot of exciting developments have occurred in the field of heart failure since you were with us 7 years ago. Yet we are still challenged by poor penetrance into the community for prevention and appropriate treatment. The Million Heart campaign also showed how hard it is to move the needle. Few thoughts from you at how we, AHA, ACC, can contribute to spreading knowledge to non-cardiologists and the community at large, including those who have not yet sought medical help.
You know, Bill, good morning, first of all, and thank you for that. Bill knows that we've been wrestling with this issue. It's hard. You know, people say, gosh, you know, if only we had more data and prevention, we could then step forward and do so much more. We don't have all of the trials we'd like to have because prevention is much harder than treatment. It's much harder to identify the surrogate markers of disease and show that we've moved those. And it's much harder to engage people that are ostensibly asymptomatic. And that's a challenge with that because most preventive therapies come at a cost. But I think for those of us that are deeply embedded in organizations like the AHA and the ACC, we are tirelessly looking for new relationships, new partnerships, new alliances in the community. We need community champions. We need to outsource this information to trusted voices in communities that can really bring the right decisions to the table. But here's the thing that I think is so important. It begins and ends with lifestyle, things that are volitional. In communities around the world where the lifestyles are the healthiest, guess what? The disease burden for coronary disease, hypertension, heart failure, stroke, are low. So it's not because we've given drugs to people. It's not because we've screened people with echoes or we've done BNP testing. It's because there are populations on the globe that have adopted healthy lifestyles. So as we think about exporting what we know about prevention to the community, we need to, in the same breath, export what we know about healthy lifestyles. And somehow or another, evoke enough culture change. Maybe it starts at the grade school level, where people engaging with life differently, being more physically active, staying away from certain toxicities, and perhaps we re-engineer our communities vis-a-vis clean water, air pollution. I don't want to get too far down that road because I have to remember I'm a cardiologist, but I do recognize that I'm also an advocate for reduction in cardiovascular disease burden. And I think it really has to do with something that's happening in communities. And we need to work more carefully with sociologists, anthropologists, leaders in community, teachers, clergy, community activists, because these messages about heart healthy living, lifestyle messages are incredibly important. And Dr. Bhimaraj, don't forget the point that you made. So much of the adverse burden of poor health comes from the way communities are hardwired, things that are out of the control of most people. So when we think about, can we use public policy to reconfigure communities so that there's a better opportunity to attain health? I think that's important. The last thing I'll say about this, Bill knows that we started to change our narrative. We don't talk about life expectancy anymore. What we're talking about is lifespan. And is that lifespan a healthy lifespan? Some would call it the health span. The longer we can live healthy, the better.
Thank you for that. And the next question here from the audience is, African American patients and healthcare colleagues are more skeptical of COVID vaccines due to their historical mistreatment by the medical community, yet tragically are more likely to die from COVID, as you pointed out. I appreciate the efforts you and other Black physicians have done to battle misinformation. And as a white physician, how can we best advocate and address this skepticism?
So it's a brilliant question, and it is so topical. Just yesterday, we released an instructional, informational video on the National Academy of Medicine website. It is from me, Cato Laurentian, Hannah Valentine, the former Chief Diversity Officer at the NIH. The three of us and others are specifically stepping up and releasing this information to the community, answering the questions in plain English, letting the community know that these vaccines are safe. And we're targeting that information, that material, to the African American community. So again, if you go to the National Academy of Medicine, NAM.org, on the front page, you'll find the video that we just posted yesterday. So that is helpful information for others to know. It really has to come down to one word, though. It's about trust. Most people believe that there's something peculiar that the vaccines came on board in 10 months. It's really not true. The foundational science started a decade ago. And so once you go through that exercise, it's important. Most people believe the vaccine wasn't tested in people that look like me. That's not true. In the vaccine that we attribute to Pfizer, 9% of the participants in that trial were Black, 13% were Hispanic. And here's something that nobody appreciates until you look carefully at the data. The vaccine efficacy overall was 95%. And the cohort that was Black, the 9% that was Black, 100% efficacy. Not a single Black person in that trial that got vaccinated developed COVID-19. That is a statement of fact. It was tested in Blacks, and it worked incredibly well in Blacks, but that information hasn't been promulgated.
Thank you so much. We are a few minutes over, and I really want to thank you and your time and your perspective. Very inspiring as always, and very eloquent. And I'm sure we will incorporate the words of wisdom in every walk of our life. And you've covered really a breadth of and wealth of information. Before we end, I want to also alert our audience that we have our patient conference coming up on April 24th. One of the aspects in all this equation, it's centered around our patients. And for patient empowerment, the conference is on April 24th. Now it's virtual, so no matter where you are in the world, you can share that information with the patients. And it's focused on life with heart failure, stress management, how to cook. We have an excellent chef with demonstration on how to cook low sodium diet. So please look at the information on our DeBakey website and register for it. And again, I want to really thank Dr. Yancy for his time, and you all have a very good evening. Thank you, Dr. Yancy.
Thank you.
Thank you very much.